So we'll start the session. So I'm Dr. Samarasinghe, consultant rheumatologist. So today we are going to discuss on spondyloarthropathy, so one of the common disorders in rheumatology. So before we go ahead, I would like to explain the terminology. So spondyle, so I think everyone knows spondyle is vertebra or spine. So we have these closely related terminologies like spondylosis, spondylitis, spondylolisthesis. So if I briefly explain, so spondylosis means a degenerative condition. So due to wear and tear changes in the spine, you will get this condition is called spondylosis, very common in especially from middle age to it starts, and you get changes in your X-ray, you get back pain. So it's a wear and tear change with aging. It's called spondylosis. And spondylitis is inflammation of the spine. So this is the area we're going to discuss today. And then spondylolisthesis means spinal instability. So this is where your vertebrae slips one over the other. It could be either anterior or posterior. So there's another terminology called spondylolysis. So this is due to a past fracture. It's part of the vertebra, and so that leads to spondylolisthesis. So these are different meanings, but closely related. But today we're going to discuss on spondylitis. So that is inflammation of the spine. Yeah. So spondyloarthritis. So this is actually an umbrella term to a group of rheumatic disorders. So we will discuss them. So they have common clinical features, common pathology, and investigations, and even the management is similar. So, but they have little differences. However, they are all associated with HLA-B27 strongly. So they are all described as spondyloarthritis. So this disorder is characterized by the following clinical features. So they will have sacroiliitis. I will go through these in detail in the coming slides. And they have spondylitis, peripheral arthritis, enthesitis, tactilitis, and then inflammatory itises. So as I said, it's a group of disorders. So I think you have heard of ankylosing spondylitis. I will briefly explain these conditions. So ankylosing spondylitis is a patient with back pain and stiff back, stoop posture. So this is the classical disease out of this group of spondyloarthritis. And then you have the reactive arthritis. So this is, I think you have heard, this is following infection. So the classical infections are chlamydia, salmonella, shigella. So I think this is the one that previously called Rita's syndrome. Actually, it's a subset of reactive arthritis. There you get arthritis, urethritis, and conjunctivitis. So this is after an infection. And then you know about psoriasis. So psoriatic patients can have arthritis, and it can involve the spine. So this is also one group of disorders. And then we have the inflammatory bowel disease related arthritis. And finally, undifferentiated spondyloarthritis. So what this undifferentiated spondyloarthritis is, so they don't have any features like there's no preceding infection, no psoriasis, and no inflammatory bowel disease, but they have spondyloarthritis. So how it differs from ankylosing spondylitis is, so to diagnose ankylosing spondylitis, you have to have X-ray features. But in undifferentiated SPA or spondyloarthritis, so you get early changes, which is only seen in MRI. So when you don't have features on X-ray, but you still have spondyloarthritis, which is detected by MRI scan, and they are grouped into this disorder, undifferentiated spondyloarthritis. So this is a very important entity because this allows us to early diagnose and treat spondyloarthritis. So as I said, I was going through the terminology. So spondyle is that resembles vertebra or spine. That's the terminology for spine. So we have few different terminologies which are closely related but have different meanings. So you have spondylosis, which is very common. So this is due to normal wear and tear process and degeneration of the vertebral column. So patient will have back pain, and it's very common. You get osteophytes. So it's called spondylosis. And then you have spondylitis, which is inflammation of the spine. So this is what we're going to discuss today. So when there's inflammation involving the spinal components, call it spondylitis. And then spondylolisthesis is spinal instability, where you have vertebra slipping or one over the other. You can have anterior or posterior spondylolisthesis. And there's a condition called spondylolysis. So that is where the parts get fractured. It's part of the vertebra, and that leads to spondylolisthesis. So they are closely, the term looks closely similar, but they are different and have different meanings. So we're going to discuss today on spondylitis. So we're going to discuss on spondyloarthritis. So this is an umbrella term to a group of rheumatic disorders. So very common in rheumatology, and they have different diseases but have common clinical features, common etiology, and even the investigations and management is similar. And they are all associated strongly with HLA-B27. So these are the features that this group of disorders are characterized by. So they can have sacroiliitis. So I will go through these features in detail in the coming slides. They have spondylitis, peripheral arthritis, enthesitis, dactylitis, and inflammatory itises. So as I said, it's a group of disorders which have similar features but slightly different and different presentations. So we have ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease-related arthritis, and the undifferentiated spondyloarthritis. So as I said before, reactive arthritis is when you have a preceding infection leading to the arthritis. Uh, and the common infections like Salmonella, Shigella, and Chlamydia. And classically, this was called Rhesus syndrome when you had arthritis, conjunctivitis, and uveitis and urethritis. And this is a subset of reactive arthritis. So when there's infection preceding these joint symptoms in arthritis, it's called reactive arthritis. And then psoriasis is associated with arthritis, so they can have spondyloarthritis. And when there is psoriasis, we call it psoriatic arthritis. And ulcerative colitis and Crohn's disease is also associated with spondyloarthritis. So spondyloarthritis can happen without any of these associations, and then it's called ankylosing spondylitis. And they have X-ray changes. So, and there is a group of disorders which is actually the most common spondyloarthritis, that is before developing X-ray features. So you don't have X-ray features, but the patient has spondyloarthritis, and these are called undifferentiated spondyloarthritis. So they have MRI changes and they have spondyloarthritis, but the X-ray changes have not formed yet. So I will describe these later. So this last group is very important. So this is helping us to identify patients early and treating them and reducing the morbidity and mortality. So so the reasons for the classification are both historical and practical. So they don't necessarily represent a discrete disease entities, as the clinical and laboratory and imaging findings have a significant overlap. And also the diagnosis and management is also generally similar. So the etiology is not completely understood, and there is a direct relationship between the spondyloarthritis and HLA-B27 gene. So the hypothesis is autoimmunity as other rheumatological conditions. So your own immune system is acting against your body. So there are several factors in pathogenesis. and the major involvement is in the axial articulation. So that's why this is spondyloarthritis. So the involvement is of the enthesis is the characteristic. So enthesis means where are the ligaments and tendons attached to bone, and that's the characteristic site of inflammation in the pathogenesis of these disorders, and is involved in the axial skeleton. So in the pathogenesis, they say the microbiome, the gut, mechanical stressors, and genetics play a role. So I'll briefly go through the pathogenesis. So the microbiome of the gut, when exposed to when the cells are immune cells are exposed, they produce pro-inflammatory cytokines like IL-17 and IL-22. So these immune cells get activated in the gut and they migrate to the enthesis, the joints, the spine, and they start the inflammatory process where mainly TNFs and IL-17 are involved. So that's causing inflammation. And mechanical stress can also activate these cells which produce these cytokines such as IL-17. And genetic role is there, and they have found that TLP27 is strongly associated and has a key pathogenic process in disease. So this diagram shows how the gut microbiome activates the cells, immune cells in the gut, producing the IL-22 and IL-17, and they migrate to the spine and produce the TNFs and IL-17, which cause inflammation and see it as osteitis, enthesitis, causing inflammation. So it's basically the immune cells activated by gut microbiome and then causing destruction due to immune cells. So coming to epidemiology, so it's quite common, as you can see, it's ranges from 0.1 to 1% in the general population. So 1% means this very large number, and actually only few patients are being diagnosed. So I will go through them in the coming slides. So it's a very common disorder which has been overlooked and missed. So the age group is from late teens to age 40. So it involves the younger population. It is equal in men and women, but I think we have all learned that it's more in men. The reason is clinical ankylosing spondylitis is more common in men than women. So the ratio is 3 to 1. So that's why we see more men than women, and it's felt that spondyloarthritis is more common in men. However, it's equal in men and women, but clinical spondyloarthritis is more in men, the ratio of 3 to 1. Right, so we'll come to the clinical features. So we have, so the main characteristic feature is the inflammatory back pain. So I will just briefly describe. So in rheumatology, so we are dealing with joints mainly, joints, muscles, musculoskeletal. So if we broadly divide, so it's between arthritis, so peripheral arthritis and inflammatory back, spondyloarthritis. So it's either the joints or the back. So the peripheral arthritis is mainly rheumatoid arthritis, psoriatic arthritis, reactive arthritis, and the back is spondyloarthritis. So if a patient comes with more back pain, then you have to go through the spondyloarthritis route. So you have to go through several clinical features to identify whether this is inflammatory or a degenerative back pain. So this is the definition given by the ASA's criteria, the society. So you have to have 4 out of 5 to say it's inflammatory back pain. So usually the age is less than 40 years, and it's insidious onset, and there's improvement with exercise and no improvement with rest. And pain is worse at night with improvement upon getting up. So they will have morning stiffness. So that's also an important feature. So for more than 30 minutes. So usually it's a back pain which starts at age of, I mean, it's usually seen in younger people. So when you get a patient with back pain uh, at a younger age, and if it has like an incidence onset, so you need to ask a few more questions. So ask whether, when is the pain worse? Is it more in the morning or the evening? So if it's a night pain which is worse in the morning and then improved after getting up, you're dealing with inflammatory back pain, and there is improvement with exercise. So in contrast, so spondylosis, which I described before, which is seen in elderly, and then it's more in the evening. So after being active and exercise make them worse. So that is kind of more degenerative pain. So you have to go through these features to differentiate between inflammatory back pain and degenerative back pain. And this is very important in diagnosing and not missing spondyloarthritis. So on the back, you can see that they develop stooped posture. Uh, and nowadays, because of novel new treatment, you don't see this much. So if you miss these patients and if this goes on for years, they will get a stooped posture, and this is progressive, and they eventually mobility becomes quite handicapped. So you can measure the range of motion of the spine, range of movement of the spine, and one test we use is the Schober's test. So what you do is you make a mark over the posterior superior iliac spines. So this is at the level of the dimple of Venus, and then you put another line 10 centimeters above as shown in the diagram. And then you ask the patient to bend fully without bending their knees to see the range of motion of the spine. And so the 10 centimeter mark should go above 15 centimeters. So if it is less than 15 centimeters, we say the patient has a positive Schober's test, and this indicates that the patient's spinal flexion is diminished, and it's an indication of spinal involvement. And then sacroiliac joints are very important part of spondyloarthritis, because this is one of the earliest joints to involve. So they say in spondyloarthritis, even before spinal involvement, the SI joints get involved. So early disease, SI joints are involved. And this is a very useful test to detect sacroiliac joint tenderness. So I do this test to all patients which I suspect spondyloarthritis, inflammatory spondyloarthritis. So how you can do it is you ask the patient to bend their knees, and then apply the heel over the opposite knee, as shown in this diagram, and then you apply pressure downwards. So then the patient will have pain over the side joints on the back, over the dimple of Venus. So, and this test is also helpful to differentiate between hip and SI joint pain, because this is clinically it looks like more or less difficult. The patient will point towards somewhere here, so around the hip region. So they cannot tell whether it's the SI or the hip. So this test helps to differentiate. So when you apply pressure, if the patient is pointing anteriorly towards the hip, to the front, then it's hip joint involvement. If the patient points to the back, where the SI joints are, then it's the SI joint involvement. Also, you can apply pressure directly over the SI joint. So how do you surface mark is, it's the line below from the dimple of Venus. So the line below, so these are the SI joints. So you can apply pressure directly over SI joints, and the patient will have maximum pain. So, and then the other way is you can press from either side of the iliums, so both sides inwards, and if again this can produce sacral irritation, and if it is painful, you can tell as the patient is having sacral joint tenderness. Right. So these examinations are useful to monitor the progression of the disease. So these patients, the joints in chest are involved, so they can develop loss of chest expansion. So you take the difference between the maximum and minimum chest diameter. If it's less than 3 centimeters, then it's significantly impaired chest expansion. And then due to neck involvement, so the neck of the spine involvement is also common. So then you won't lose the ability to extend the neck. So there will be a distance when you ask the patients to stand against the wall, keep your back against the wall and your heels touching the wall. Then you measure the distance from the wall to the tragus of the ear. So, and it should be less than 15 centimeters. If it is more than that, then patient have uh, difficulties in extending and keeping the normal position of the neck due to forward flexion due to spinal involvement of the neck. So this is nowadays in rheumatology we use lots of disease activity indices to monitor the disease. So this is called BASDI, and like in rheumatoid arthritis we do the DAS28 and STI, CDI. These are disease activity indices. I'll briefly go through these. So in each clinic we try to do these to see the level of disease activity. So this is like a pain scale from 0 to 10, and we ask this 6 questions. So these are 6 domains in spondyloarthritis. There's involvement. So the first one, you ask about fatigue and tiredness. See what level out of 10, and then the neck, back, and hip involvement. So that is taken as the axial involvement. So the hips are included as the axial, although they look like peripheral arthritis. So in spondyloarthritis, it's very common hip involvement. And the third one is the peripheral joints, other than the spine. So out of 10, how much they have. And the fourth domain is the overall involvement. And the fifth one is morning stiffness. So it's very important in spondyloarthritis. So in active disease, you have morning stiffness. So, and then finally, so this is the strength. So out of 10, uh, what's the degree of morning stiffness the patient scores. And the sixth one is the duration of morning stiffness. So if it's less than 30 minutes, if it's 1.5 hours, 1 hour, so you have a score for that. So the BASDI, so the final score is important to detect the activity of the disease. If it is less than 4, that is patient is kind of controlled disease. If it is more than 4, that's active disease. So it's a very useful clinical disease activity indices which helps us to monitor the disease progression. So peripheral arthritis also can happen. So and in some conditions, this is the most predominant manifestations. So I told you before, there are groups. In the groups, the other psoriatic arthritis and reactive arthritis, you have a more predominant peripheral arthritis. So the hips are common, usually bilateral, and occurs within the first 10 years of the disease. So as I said, chest wall joints are involved. So these are the costovertebral joints and the costosternal joints. So they can be involved, and then you will have impaired chest expansion, pain, and quite discomfort. And then the shoulder girdle is involved, the glenohumeral joint, the acromioclavicular joint, and the acromioclavicular and the sternoclavicular joints are involved. So the arthritis is usually asymmetrical oligoarthritis and predominantly involving the lower extremities. So in contrast to rheumatoid arthritis, which is the other common arthritis, so it is usually a symmetrical arthritis and a polyarthritis. So in contrast, spondyloarthritis is an oligoarthritis. And the other feature is, so in rheumatoid arthritis, the distal interphalangeal joints are spared, but in these spondyloarthritis, when you get peripheral arthritis, the DIP joints are involved. So that's also an important differentiating point between these two disorders. So it's very important to differentiate because the management differs between rheumatoid arthritis and spondyloarthritis. Although the initial management could be same, the biologics are when you come to the biological management, it's quite different. So it's very important to differentiate between these two conditions. So enthesitis is common in, as you can see, it's in 33% of patients in spondyloarthritis. So that's almost like 1/3 of patients. So enthesitis. So enthesis means there are the ligaments and tendons attached to bone, and you will get inflammation in these sites. So Achilles tendinitis and then plantar fasciitis. So I would also like to remind you. So these are very common in the population. So you have to note. So there's a difference. So you can get Achilles tendinopathy and even plantar fasciitis due to mechanical reasons. So I think that is more common than the inflammatory arthritis. So when you get a patient with ankle or heel pain, so the things you have to differentiate whether it's coming from the Achilles tendon. So you apply pressure over the Achilles tendon. So if it's an ankle joint involvement, so you should, the main tenderness is over the ankle joint line. So the joint line is the malleoli, so the medial and lateral malleoli. So when you apply pressure over this region, if you get, if that's the main point of tenderness, so that's more ankle arthritis. And then you can also dorsiflect and plantarflex the ankle joint. That would produce pain in the joint itself. So you have to differentiate between the joint, and then you can apply pressure over the Achilles tendon. And the other common condition is plantar fasciitis. Here, the pain is more in the soles, in the heel, and the sides of the soles. Also, other tendinopathy can happen. So below the malleolus, if the tenderness is not the malleoli, not the joint line, and below it, so laterally it's the peroneal tendinopathy, and medially it's posterior tibial tendinopathy. So these are the common conditions you can get in this region. So Achilles tendinopathy is common, and it's common due to mechanical reasons. So how do you differentiate? Again, your history. It will have the inflammatory features. So morning stiffness, more in the morning. The symptoms are more in the morning. Improves with activity. So that's more inflammatory, Achilles tendinitis. In enthesiopathy, it's the opposite, Achilles tendinopathy. So that is more after walking, more in the evening. There's no morning stiffness, right? So same as the plantar fasciitis, but even the mechanical conditions in plantar fasciitis, it's more in the morning. Probably most of you know, they will tell first thing in the morning they will have it. So it's kind of difficult to differentiate. But when you have back pain, spondyloarthritis, so that's very important. When you get these conditions, which is very common due to mechanical reasons, ask about back pain, look for the arthritis, look for the peripheral spondyloarthritis features. So you might be missing spondyloarthritis. So yeah, so that's enthesitis, which is a common condition in spondyloarthritis, and also common as an enthesiopathy in the normal population. So both conditions can happen due to mechanical reasons. And then dactylitis is involvement of the whole finger. So in ankylosing spondylitis, it's uncommon. So if you see an isolated dactylitis, this strongly suggests reactive arthritis, or psoriatic arthritis, or an undifferentiated spondyloarthritis. So the whole digit is involved, either the finger or the toes. So rather than the joints itself, you have the whole finger swollen. So dactylitis is also a feature of spondyloarthritis. And you can get eye involvement in spondyloarthritis. So this is the most common extra-articular manifestation in ankylosing spondylitis. So seen in 20 to 30% of patients. And so they can present with red eye, painful, and sometimes impaired vision. So you should urgently take an eye opinion for these patients. So and then they will give local treatment. So it's an important symptom and finding in spondyloarthritis. In psoriasis, as I said, there will be psoriasis predominant spondyloarthritis. So scalp psoriasis, is important. That's why I put this picture. You might miss it because it's hidden in hair, and if it's very mild, patients will not notice it. It's usually in the hair margins. So in a patient with back pain, if you think inflammatory, look for scalp psoriasis or check in the elbows, knees to see whether there's these classical features of psoriasis. Right. So we come to the investigations. So it's mainly there are not much investigations in spondyloarthritis. Few lab tests and imaging. So imaging is the primal mode of investigations leading to diagnosis. So we'll go through the X-ray first. So if you suspect a patient with spondyloarthritis, please do an X-ray and request for X-ray sacral joints specifically. So you can do a pelvic X-ray, but SI joints X-ray would show the SI joints clearly. So the sacroiliitis is usually bilateral and symmetrical, uh, and I think the images are not clear. So we'll go through uh, the sequence of sacroiliitis. So initially, first you can see the blurring of the subchondral bone plate, and these lead to irregular erosions of the margins of the SI joint. So the SI joint is the joint between the sacrum and the ilium, and so this can lead to a pseudo whitening. And then later it can go into sclerosis, then narrowing, and finally fusion. So let's try to see these features. So can see probably not very much clear if you zoom in, tiny erosions. So this is the ilium, this is the sacrum, and this is the sacroiliac joint. So in the joint margin, you can see some erosions, and the larger lines point towards the sclerosis. So you can see the sclerosis here, and the joint space. If you compare these two, this started to get narrowed. So usually the changes are seen in the iliac side of the joint, so the iliac side and the lower part of the SI joint. So we take the SI joint, usually seen in the lower part and on the iliac side. So these X-rays are again showing narrowing. As you can see, the whitening, sclerosis, and the narrowing of the SI joints. And this X-ray shows that finally they are fused. So that's what we call ankylosing. Right. So these are the features, sacroiliitis features that happens in the X-ray, and when you have them, you call them ankylosing spondylitis. So in the spine, you get enthesitis of the annulus fibrosus. So you know in the disc you have the annulus fibrosus, which is a ligamental structure, and then you can have inflammation. And then so this leads to squaring of the vertebra. So this is the loss of normal concavity of the anterior body. Usually there's a concavity like this, and it's lost in this condition. So you can see squaring or straightening of this border. And then erosions at the anterior and posterior edges of the vertebral end plates initially leads to slight erosions. So you can see, and then sclerosis leads to increased opacity, and these are called shiny corner sign. And these erosions are called Romanus lesions. So this is due to erosions at the anterior and posterior edges of the vertebral end plate. And the ossification of the annulus fibrosis leads to the syndesmophytes. So the disc finally gets ossified, and you can see them as osteophytes in the X-ray. So the bridging osteophytes leads to fusion and leads to the bamboo spine, which is classical of spondyloarthritis. So when we come to MRI scan, so I put this slide. So earlier, so I think even when we were medical students, we were taught about ankylosing spondylitis. So as you can see, this is the modified Joe criteria developed in 1984, and you have to have these X-ray features. So it is sacroiliitis that which I described earlier. You have to have one of these radical feature with one clinical criteria to diagnose ankylosing spondylitis. So So as I mentioned here, so the delay in developing these X-ray features is about 7 to 10 years. So during this era, so ankylosing spondylitis were diagnosed after X-ray. So patients were presented after 7 to 10 years of disability agony. So this caused a huge delay in diagnosis. So that's why the new undifferentiated spondyloarthritis classification came, and people started doing MRI scan to detect the condition early, because by the time the X-ray changes appear, much damage has done, and so these are young patients, and they have lost significant amount of valuable life in their younghood. So MRI is important, so they can detect the changes even 10 years before the X-ray findings. So it's a very important part of the management of spondyloarthritis. So in active inflammatory conditions, they can have bone marrow edema, that is osteitis, and then capsulitis, synovitis, and enthesitis. So, and then chronic changes are sclerosis, erosions, fat deposition, and bony bridges and ankylosing finally. So it is very important because not only to diagnose, so these diagnose 10 years earlier than the X-ray, so it's very important the diagnosis. Also, it can say whether it's active or chronic, because like treatment is needed only for active spondyloarthritis. So if it is chronic, so the management won't change. So this is important because biologics are given for active disease. So if you have developed chronic disease, there's no point of wasting biologics, which is kind of very expensive and it is quite not frequently available. So it is very important that we can see active changes. Right. So laboratory tests, there are not much of lab tests. 15% of patients will have a normocytic normochromic anemia, and the ESR CRP levels is elevated only in 75% of patients. So this is very, very important. So you can have patients with normal ESR and CRP. That doesn't mean patient does not have inflammatory arthritis. So it can be normal in 25%. And the HLA-B27 is seen in 92% of patients. ALP could be elevated in 50%. Right, so coming into diagnosis and classification. So if it is more axial, it's whole axial spondyloarthritis. And when you have X-ray changes, we call it ankylosing spondylitis. And if it is non-radiographic, which is then found in MRI scan, which is called the undifferentiated spondyloarthritis. And if it is more involvement of the peripheral joints, the other peripheral joints, it's called peripheral spondyloarthritis. So it's two groups mainly: axial spondyloarthritis, either radiographic, which is also called ankylosing spondylitis, and you have the non-radiographic axial spondyloarthritis, which is much more commoner and which is what we treat now. And then you have the peripheral arthritis. So this is a very important slide, so hopefully you can read it. So so this is the ASAS group for spondyloarthritis, developed this classification criteria. So if you have a patient, especially, so back pain for more than 3 months, especially less than 45 years, young patient, so go through these clinical features, spondyloarthropathy features, right? So, so if you have inflammatory, so see whether it's inflammatory as I described before, whether it's in the morning, and morning stiffness and improves with activity. See whether it's inflammatory back pain, and then look for any arthritis. So it's usually in the lower limbs, and then oligoarthritis, and look for enthesitis, uveitis, dactylitis, psoriasis. So these features look Crohn's colitis, ask from history, there's family history, and inflammatory markers. So go through these features. So if you have one or more of these features, and if you do an X-ray and if you have sacroiliitis in it, you can classify it as spondyloarthritis. So the sacroiliitis could be either X-ray or MRI. So MRI, it should be active inflammation, as I discussed before, and then X-ray findings, sacroiliitis as per the modified BBOX criteria. So basically, if you have the back pain, you think it's a young patient, more than 3 months, go through these features. If you have any of these, either inflammatory back pain or peripheral arthritis, and if you do an X-ray and if the patient has sacroiliitis, you can classify it as spondyloarthritis. So if X-ray is normal, we do an MRI scan and it shows sacroiliitis, again we can diagnose or classify spondyloarthritis. So say these are, so the X-rays doesn't show, MRIs doesn't show, but you do an HLA-B27 and it is positive. So then you have to have 2 or more of the SPA features. So here you just need 1 if there's imaging findings. Here you need 2. Right? So it's basically in a patient with back pain, young patient, more than 3 months, you do imaging, and if there's sacroiliitis, and one or more features, spondyloarthropathy features, you can classify as spondyloarthropathy. Say if the imaging is negative, you do HLA-B27, and you have 2 or more of these features, you can classify as spondyloarthritis. So that's the axial spondyloarthritis. Next slide shows peripheral spondyloarthritis. So peripheral spondyloarthritis, so it could be either peripheral arthritis or enthesitis or dactylitis, plus one or more of these spondyloarthropathy features: uveitis, psoriasis, Crohn's, preceding infection, imaging findings, HLA-B27. So if you have even one of these features, you can classify as peripheral spondyloarthritis. If you have these features, you have to have 2 or more. So this is arthritis, enthesitis, dactylitis, inflammatory back pain, and family history of spondyloarthritis. So these are more specific features here. So if you have even one with the peripheral arthritis, you can classify them as peripheral spondyloarthritis. In this group, you have to have either at least 2. So sensitivity of is 77% of these classification criteria, and specificity is 82%. Right. Coming to management, so I'll go through the EULA guidelines for recommendations for management of spondyloarthritis. So I'll briefly, so in the summary, what this says is, so let's say, so you classify or diagnose a patient with axial spondyloarthritis. So for all patients, provide education, exercise, stopping smoking. So you can refer to the physiotherapist. And swimming is the best exercises for spondyloarthritis patients. So pharmacological management. So first you give an NSAID. So it could be celecoxib, etoricoxib, NSAIDs. And then you see the patient in 2 weeks' time. And you do a best die, as I described before. And if it is more than 4, if the patient is still active, then you change the NSAIDs to different group. So say from celecoxib to etoricoxib. And then you see again in 2 to 4 weeks' time. If still the patient has active disease, then you switch on to biological treatment. And then again, so similarly, you assess regularly. So if one biologic is not working, we can change to another one. And so the first line, usually we use the TNF inhibitor therapy. And then a second line, we can think of giving IL-17 inhibitors. So that's basically the summary of treatment of spondyloarthritis. So it could be pharmacological treatment and non-pharmacological treatment to start with. So NSAIDs give 2 weeks each, change if it's not responding. And if it's still active disease, best die more than 4, we go for biological treatment. And usually TNFs, and also you can give IL-17 inhibitors. So biological demands have changed the way we look at spondyloarthritis. So I think even when we were medical students, we were taught that this is a progressive disorder with poor prognosis, with significant impairment in quality of life and mobility. Initially, we had the mainstay of treatment were only NSAIDs and physiotherapy. So it's was quite a tragic disorder because spine is very important and hips are mainly involved in spondyloarthritis. So mobility is significantly impaired in these patients and sexual life is quite deteriorated because the hips are involved. So it's a very pathetic condition before the biologics were introduced. So biologic became a life changer for these patients. So you meet these patients and they say biologics just changed their life. So and they can spend like almost normal life after starting treatment. So the biologics were introduced in around 1990s with the advances in molecular biology. So these are engineered drugs that target specific inflammatory cells and then cellular interactions and cytokines. So they directly target the inflammatory cytokines, as I described before. The IL-17s, the TNFs. So that's where the inflammation, the pathological process are active. So they target these molecules straight away. So they reduce the symptoms and signs and even arrest the progression of the disease. Um, Right, so they have different mechanisms. So, like we have infliximab, golimumab. So they act on the TNFs. So it can either be inhibiting the molecule itself or the receptor. So they have we have a significant number of different biologics. So these are the ones we have in Sri Lanka. Um, and then the IL-17 inhibitor we have is sedukinumab. But in the world there are a number of biologics and they're producing more and more biologics, and these are a life changer in spondyloarthritis and significantly have improved the management of spondyloarthritis. So there are few negatives of these drugs. So they cost a lot. So before the economic crisis, I think infliximab vial would cost around 150,000. So you have to give this monthly, and this it's a huge cost for the government because it's provided free. So I don't think up to now we don't have it in the private sector. So I think the cost should have invariably have gone up after the economic crisis. So these drugs cost huge amounts, and however we still have drugs in the country, but not persistently. So we have like for short durations, and also when providing patients, there's a limit for how much you can spend per patient in the government. So usually we can order only 6 vials usually for a patient. Um, so yeah, there's waiting time. So drugs are not always available. We have to order the drug and wait for time. And again, the supplies are not persistent. So we have significant shortcomings in providing this medication for our patient. So infection is a problem. So because we are inhibiting the TNFs and the molecules involving in protective mechanism against infection, we are prone to infection. So tuberculosis is one of the serious infections we are worried about, and even other infections happen. So we have to vaccine these patients usually, pneumococcal vaccine prior to giving the biologics. So this we thoroughly screen the patients before giving biologics. So we have to screen for tuberculosis. We do a chest X-ray, MAN2. So we have to rule out hepatitis B, C, and HIV, and we do the basic tests, blood tests, and we do a echocardiogram as well because like TNF inhibitors are not given in grade 3 and 4 heart failure. So we have to know the baseline cardiac functions prior to giving these medications. Right. So I would like to quickly go through a study which I did in 2016-17 in Ragana to see the Sri Lankan presentation of this condition. So we actually decided to do the study because we got quite significant number of patients within a short period. So within 2 months, we got about 6 patients of spondyloarthritis. So they were included according to the ASA's classification criteria, which I described earlier. Um, so out of the 6 patients, so 4 were axial spondyloarthritis and 2 were peripheral SPA patients. So And mind you, so none of these axial SPA patients had made the modified Neuro's criteria because all of them, the X-rays were normal. So we would have easily missed them if we didn't do the MRI scan. And then we have the peripheral spondyloarthritis patients. So two of them, and one psoriatic arthritis, one differentiated peripheral SPA. So the demography of these patients, all patients were males. So this is telling with the epidemiology. As he said, more clinical spondyloarthritis is seen in males. So the age range was from 23 to 49. Average age was 37 years. However, the mean age of onset was 31.6. So this was telling with the epidemiology, which is from teen to 40s. So the symptoms of our patients, 4 patients had inflammatory lower back pain, obviously the ones with axial SPA. Only 3 were positive with Schober's. Only 3 had SI joint pain, and 2 were peripheral arthritis. So the main symptom in 3 of the axial SPA patients was neck pain and stiffness, so not the lower back pain. The main involvement was neck. So you can have patients with neck pain they present with who has spondyloarthritis. And then enthesitis was seen in 4 patients, dactylitis in 1 patient, and anterior uveitis in 1 patient. So the BASTI, the disease activity ranged from 7.3 to 1.2. 5 patients had active disease more than 4 BASTI, and the remaining patient had already improved disease activity with the NSAIDs. 4 patients had high inflammatory markers. Again, you can see 2 patients, the inflammatory markers were normal. HLA-B27 was positive in 5 patients, and sacroiliitis on MRI scan was seen in 4 patients. So none of them had conclusive X-ray changes. So again, I want to highlight X-rays were normal, but still they had spondyloarthritis and MRI was positive. So how we manage these patients? So 3 patients we could manage with NSAIDs. So that's very good. So with simple NSAIDs we could manage them. And we had to give DMARDs for patients who had peripheral arthritis. 1 patient was having chronic kidney disease, so we gave him infliximab, as we cannot give NSAIDs, but again he developed hypersensitivity to that. So the peripheral spondyloarthritis patients, we had psoriatic arthritis treated with methotrexate and NSAIDs, and the peripheral undifferentiated patient we managed with methotrexate. So lifestyle, 2 had lost their occupation, and 2 had to change their occupation. So this disorder significantly affects the life of patients. So the important implications of this study. So we found that 6 patients came within a short period, 2 months, for a single unit. So it's quite common in the society. And they were diagnosed in the specialized unit after filtered at several levels. So they were diagnosed only at the rheumatology unit after some time. So we are only seeing the tip of the iceberg because we don't do MRI scans for these patients. So only few patients are being picked and referred to rheumatology clinics, but we are just seeing the tip of the iceberg. So as we study, so ankylosing spondylitis, the prevalence is 0.3 to 0.5%, but when you do the MRI scan, so that is spondyloarthropathy, it is increased. So you have 1 to 2%. So this is even higher than rheumatoid arthritis. So it's a condition equally or even more than rheumatoid arthritis. So yeah, so moving on to the next slide. So in this study, the delay in diagnosis was 9 years to 6 months, the range of duration. So average delay was 5 years. So this is even seen in the world as well. So in other countries, so this study was done in Europe, and you can see the delay was 8 to 11 years. However, this was in 1981, but with the advances of MRI scans, the delay has shortened. So why this should be diagnosed? So why this delays? Basically, there's no pathognomic clinical feature or a laboratory test to diagnose this. And then again, lower back pain is extremely common in the general population. And then the inflammatory origins are not carefully sorted in the day-to-day practice because it's very common. And then the previous classification required X-ray changes, which developed only after several years. So that's main reasons for the delay of this diagnosis. So why we should diagnose this early is, so this is the disease of young onset. So that's why you should um, diagnose this early. So if you delay treatment, so you're losing function during years that are normally productive. So younger age, which is usually productive for your life and for the country. So that's what the importance of diagnose these conditions early. So, and why we should diagnose early is because earlier, even we diagnose uh, at an earlier stage, still didn't have much treatment options. But now with biological treatment, we can treat them early in the disease. So it's very important to diagnose this condition early. So we should be having more education programs like this to describe about this condition, because you don't have to wait till X-rays. You can do MRI and diagnose them early. So this should be taught to undergraduates. So these were the suggestions from our study, and so new classification criteria should be introduced to the medical officers, OPD and the OPT and the general practices. And then we should formulate protocols to identify these patients early. So this is the last slide. So I want you to highlight, so this as the take-home message. So in your day-to-day practice, so I know you see lots of patients with back pain. So if it's a young patient, less than 45, and it's more than chronic back pain, then please go through these features. So see whether it's inflammatory or not, whether it's in the morning, whether there's morning stiffness for more than 30 minutes, and whether it's improved activity, and see whether he has any arthritis, any enthesitis, any plantar fasciitis or Achilles tendinitis, any history of eye involvement like red dye, painful red dye with impaired vision, any dactylitis, psoriasis, ask history of inflammatory bowel disease, and see whether there's any family history. So do inflammatory markers, CRP, and do an X-ray of SI joints, and then refer to a rheumatology clinic. So when you have patient with this back pain, please go through these symptoms, and you can do an X-ray SI joint and a CRP, and then you have to refer them to the rheumatologist. So we can pick these patients early and treat them early. Right, I think we have come to the end of this presentation. So thank you for listening, and if there's any question, please pass on.
Sir, we have a few questions. The first question is, what is the temporal relationship of
Yes.
infection in reactive arthritis?
So it's usually prior to, there's no specific definition. So usually during the infection or just after infection. So like between 1 to 4 weeks, if you have history of infection, then you can diagnose as reactive arthritis, but there's no specific diagnostic criteria like a duration.
Another question is, this is a very common question, sir. The primary care management and the role of a primary care physician in diagnosing and treating this spondyloarthritis, except for prescribing anti-inflammatory drugs, and when to the indications to refer to a specialized unit.
Yes, so I think, as I said in the slide, so I'll just go through that because it's an important slide. So say if you have a back pain patient, less than 45 years and more than 3 months, if you have any of these features, please refer to a rheumatologist, because so do an X-ray, and you can do it, or we can do it from our clinics. But if you have any of these features, refer to a rheumatologist, because they should be closely monitored. So you can have, once it is diagnosed at a rheumatology center, you can have a shared care kind of thing. That's what is done in developed countries. So it should be regularly seen at a tertiary center or by a rheumatologist, but you can have like a shared care. So in between, you can treat because NSAIDs is the mainstay of treatment initially, but biologics is usually given in a tertiary center or where there's a rheumatologist. So I think the role of the doctors are to, if you have these features, then refer to a rheumatologist. So then I think the diagnosis should be made at a rheumatology center, and follow-up should be there, but you can have intermittent follow-up at the periphery as well.
Sir, whether there are any rehabilitation methods that can be used in peripheral hospitals and at home, or whether there are any exercises that we can teach them to do?
Yes, so I think so. Physiotherapy is very important. So you have to refer to a physiotherapist. So there's a comprehensive methods of rehabilitation for these patients. So if you have a ankylosing spondylitis patient or a spondyloarthritis patient, please refer them to a physiotherapist. A good exercise for them to do is swimming. So people who cannot swim, that's an issue. But you have to get advice from a physiotherapist for a patient with spondyloarthritis. Yes.
Also, sir, is HLA B27 available in the government sector? And if not, what is the cost like to do the test?
Yeah, so it's available in the government sector. So it's available in the blood bank. So even in now, I work in our hospitals. So we coordinate with the blood bank, and then there's a form to be filled. So it's available in the government sector. In the private sector, it's also available. It costs around, I think, before the economic crisis, about 28,000, but surely it should have gone up by now. So it's available. So if you want to do it, but it has to be signed by a consultant. So you have to go through your consultant to get it done, and it's through the blood bank.
Or I say, is there any association between spondyloarthropathy and regular intense exercises?
Sorry, I didn't get the question. What's it?
Is there any association between the spondyloarthropathies and regular intense exercises, doing regular intense exercises?
Yeah. So in the pathophysiology, as I said, mechanical stress could it could cause production of these cells, which causes the IL-17. So it probably, so not all people with everyone who do exercises would get it. It's like if you have a genetic predisposition, mechanical stress could be one cause. So and then the gut microbiota also plays a role. So there's no direct relationship like with exercise and getting spondyloarthritis. But if you have a predisposing condition, mechanical stress could be one causative agent, as explained in my presentation.
Sir, can you briefly explain us about the side effects on the treatment and whether this treatment have a negative effect on fertility?
The
The
biologics.
long-term use. Yes, sir.
Yes. So biologics, the main side effect is infection. You are prone to infections, but we give lots of biologics. We don't see like more than the normal population. So probably you may be more prone to these normal viral infections. And the most problematic one is tuberculosis, because TNF is one of the main constituents on the immune mechanism against tuberculosis. So you're blocking it with TNF inhibitors, and this could cause significant, can cause tuberculosis, and then it can activate hepatitis B, C, HIV, uh, because your immune process is weak. So more prone to these infections. We give the pneumococcal vaccine and other available vaccines here in Sri Lanka. So other vaccines in other countries we can give. Varicella vaccine is given. Uh, so this has to be given to reduce the number of infections and side effects. So infection is the most worried one, but then you can get other minor problems like liver enzyme elevation, worsening of cardiac functions. That these are uncommon. And then regarding fertility, I've not heard any issues, but I think Even there could be minor problems like if you get the side effects, it's like a huge list. But the more common ones are infection, and then most significant ones are cardiac ones. You can have cytopenia, so we regularly monitor these patients. So anyway, we monitor our patients on DMARDs with full blood count and liver function test. So the same applies for the patients on biologics. So fertility mainly is the issue with the oral DMARDs. So for peripheral arthritis. So if you're on methotrexate or leflunomide, you have to stop the drug if you want to conceive. 3 months prior to you have to stop methotrexate. And the safe drug in for these ones are sulfasalazine. So if you're taking sulfasalazine and if you want to get pregnant, you have to take uh, folic acid 5 milligrams daily. So that will prevent fetal complications. So biologics, again, there are few biologics you can give during pregnancy. So you have to switch into these biologics. And unfortunately, in Sri Lanka, we don't have much of these biologics. So if you planning for pregnancy, then it will be an issue.
Thank you very much, sir. That's all for the questions. We
Right.
sincerely thank Dr. P.M. Samarasinghe, consultant rheumatologist, DGH Nawalapitiya and DGH Awissawella, for your excellent and a very timely, concise lecture and spending your precious Sunday morning to educate the doctors. Thank you very much, sir.
Thank you very much.
There's a link in the chat box to get your e-certificate, the post-assessment questions, and the feedback. Please fill it in to receive your e-certificate for your participation. Thank you very much.